Okay, good afternoon, everyone. Today we have two lectures. I will moderate the first one, and Dr. Ahmed will moderate the second one. The first one, the topic is aortic dissection by Dr. Mohammed Babki. Can you please prepare your slide and start?
السلام عليكم. اوكي ان شاء الله. بس اتاكد الدكتور هيثم يكون موجود. Okay, assalamu alaikum everybody. Dr. Haytham inshallah will be with us in a few minutes. So I think I'm going to start. Actually, my presentation will be mainly focusing on the management of the acute aortic dissection. As I think there is another lecture supposed to be speaking about the pathophysiology and diagnosis of the aortic dissection. The outline of this talk will be a brief introduction, the natural history of the aortic dissection, initial medical management, then the indication of surgery and the surgical planning or the strategical planning for managing such a patient. As it's well known that aortic dissection is the disruption of the intimal layer of the aortic wall, resulting in a flow of the blood in between the layer of the aorta, between the tunica media and the tunica intima, and that can propagate throughout the entire length of the aortic and even can affect the branching of the major branches of the aortic vessel. And it is considered as part of the spectrum. It's called acute aortic syndrome that include penetrating aortic ulcer, intramural hematoma, as well as the dissection. And it is one of the life-threatening condition, and all of these subcategory of the syndrome are very interrelated with similar clinical characteristics. Common complication of dissection include aortic rupture, tamponade, regurgitation of the aorta, as well as organ malperfusion. This is the common classification. As everybody knows, they have the two common classifications for aortic dissection, the Becky and the Stanford. Stanford type A, which constitute both type of the Becky classification, type 1 and type 2. And this is include any dissection that involve the ascending aorta, or mainly the intimal tear that originates from the ascending aorta up till the aortic arch proximal to the left subclavian artery. any intimal tear that originate beyond that landmark is considered a type B Stanford dissection, or type 3 with its classification A and B of the Becky classification. Our talk today mainly will be focusing on the type A dissection. The natural history of such a group of patients is usually related to the type and the extent of the dissection, in addition to the nature and severity of the complication that develop. And it is estimated that around 1 to 2% risk of death per hour is considered for such a group of patients who present with acute dissection, and it's reaching a mortality rate up to 60%. Usually, risk factor for early death include involvement of the ascending aorta or the arch. Hypertensive patient has a higher risk of death than other group of patients, for example, patients with connective tissue disease or patients who had iatrogenic dissection, less risk of death than patients who are hypertensive and develop acute dissection. Of course, larger size of dissected area is a risk factor for death. Those patients who present with complete or near complete thrombosis of the false lumen have somehow a little bit reduced risk of subsequent rupture and death. This chart is showing the survival, long-term survival, and the risk of death of both the type of patient, either type A or type B. And it is apparent from here that the survival in the early after the dissection, it drops dramatically for type aortic dissection up to 40%. And thereafter, it goes to a plateau phase. So long-term survival almost like stable, but the critical time for dissection in the first phase of the disease, after that, usually patients who survive that, the mortality rate is stable. What is the difference for type B dissection? When you see the mortality rate goes dramatically in the initial phase of the disease, then goes to a plateau phase, and later on, after 3 or 4 years, the curve starts to rise up with higher mortality, higher later mortality for type B dissection. The most common mode of death for this group of patients, either from false lumen rupture, and that results in hemo or pericardium or hemomediastinum, and for the early period of death, usually results from either delayed rupture or dysfunction, organ dysfunction, secondary to arterial occlusion. But those group of patients who survive the acute phase still have a greater risk of death, and this usually related to false lumen aneurysmal dilatation and late rupture, which can occur months or years later. Some group of patients may have a new dissection, redissection, that occurs in uninvolved segment and may result in another consequences or rupture. And this is usually a patient with connective tissue disease. I'm not sure if Dr. Haytham joined us or not yet.
I'm here, exactly. Go on.
Okay, thank you, Dr. Haytham. Just to welcome you, and we're glad actually to have you with us in this session.
Excellent. Mohammed, can you go back to the previous slide? I just want to say something.
This one?
How do people die from acute dissection? Usually there are three or four modes of death in acute dissection. Acutely, I mean. You mentioned
either
rupture. Okay.
Yes.
Rupture is one of them.
Heart failure, ischemia, cardiac ischemia or heart failure.
Cardiac ischemia from involvement of coronary, basically coronary malperfusion.
Yeah.
That's number two.
Number three is
tamponade. Exactly. So tamponade, even if there is no rupture, sometimes what happens is what we call aortic sweating, almost invariably, when you open the pericardium in those patients, you will find a bloody effusion, even if there is no rupture. Okay, this is the reactive, sympathetic reaction to the dissection. And this can cause tamponade. Even if there is, in the absence of frank rupture, patients may die from tamponade. So they die from tamponade, from rupture, coronary malperfusion, and the fourth mode of death is acute aortic insufficiency. Acute aortic insufficiency or acute aortic regurgitation is very poorly tolerated. It's not like chronic aortic insufficiency or chronic AI. Acute is poorly tolerated. They go on flash pulmonary edema and respiratory failure. So basically heart failure. Another mode of death in these patients is distal malperfusion, like brain malperfusion. They can have strokes, or they can have gut ischemia. Gut ischemia kills you within hours, basically, within 12 hours. But yeah, so that's this is how patients die in the acute phase of aortic dissection. Carry on, please.
Thank you. So the goal of initial medical therapy or in normotensive or hypertensive patient, as a patient with acute dissection, they might present with in all different presentation. Either can present normotensive or hypertensive, usually hypertensive, but sometimes they may present as well hypotensive, especially if they are tamponading or they went to heart failure. So if the patient is normotensive or hypertensive, the medical treatment goal should be focused on decreasing the shear stress on the aortic wall and suppression of the propagation of the false lumen. And this is achieved by what's called the anti-impulse therapy. And as I said, the goal of this anti-impulse therapy is the decrease the transmural aortic wall stress. And this is basically by decreasing the systolic blood pressure and reduce the possibility of rupture. Second is decreasing the shear stress in the aorta and the rate of the rise in aortic pressure. And this is achieved by controlling the 3 B's, the pressure, the pulse rate, and pain management. And the goal for blood pressure target is around 90 to 110 systolic with a target heart rate less than 60 beat per minute. And this usually achieved by the beta blocker as a first-line agent, commonly esmolol and labetalol. Other second-line medication including calcium channel blockers, either dihydropyridine or non-dihydropyridine, in addition to sodium nitroprusside in some patients. Pain control usually achieved using narcotic analgesia. In case of patient presented with in hypotension, first approach is to introduce, resuscitate him with fluid, improve the blood pressure, and accepted systolic blood pressure around 90, which is the what's called the permissive hypotension. The goal is to increase the preload and improve the cardiac output, ensuring adequate end organ perfusion. If the patient is having significant pericardial tamponade, I know most are not favoring introducing a pericardiocentesis catheter, but I have read some might, in certain situations, might do it temporarily till they reach the operating room and manage the patient definitively.
It is not recommended to do this. A pericardiocentesis?
Because I have read in some, they wrote in certain situations, you may do it temporarily till
you may, but it's not an exam answer, because if you have rupture, basically you will have a free-flowing path for the blood to exit and bleed to death. So it's not recommended to do this. Support the patient with fluids, with vasopressors, and go to the operating room as quick as possible. One comment about anti-impulse therapy. Do you guys know the concept of delta P over delta T, dP over dt? Anybody read about this before?
You decrease the tearing over time. So you want to decrease this so you can stop the
Exactly.
propagation of the.
So that's the principle of anti-impulse therapy is to decrease delta P over delta T exactly over time, and that's ventricular contraction. Okay, so if you use vasodilators like ACE inhibitors or nitroprusside as a first-line agent, you in fact increase ventricular contractility because you drop the afterload. You increase the force of ventricular contraction. You increase delta dP over dt, and this is fatal. This can be fatal, actually. This can cause worsening of the dissection. So that's why first-line therapy is beta blockers, esmolol or labetalol. Without decreasing contractility with a beta blocker, you cannot start a patient on vasodilators like ACE inhibitors or nitroprusside. Thank you.
This is the recommendation from the latest consensus of AATS SDS on the management of aortic dissection. And it is class 1 indication to start beta blocker in the initial management without severe aortic regurgitation. Calcium channel blocker is an alternative agent, class 2A, and as Dr. Haitham said, it is recommended as reasonable to initiate rate control before you start the vasodilator medications. As we said, our target is the around 90 for patient who present hypotension, and for sure class 1 indication to control pain in such a group of patients. So the surgical indication or surgical indication for surgical intervention. Initially, the goal of surgery in acute dissection is to prevent or treat the catastrophe while restoring the blood flow to the true lumen of the aorta. And the catastrophe is like aortic rupture, occlusion of the coronary ostia, or a progression of into the aortic valve and lead to acute valvular incompetence. And the presence of ascending aortic dissection by itself is an indication for operative intervention in almost all patients, but high-risk group of patients. And the term high-risk group of patients is not well defined in patient with acute dissection, but basically patient a very old age by itself is not a contraindication or not absolute contraindication, but very old, frail patient or those with end stage disease or like advanced stage of cancer or dementia, or patients who presented with coma. Those kind of patients may be deferred from surgical intervention and go for medical management. Other than that, most patients, even if they have a stroke or paraplegia, it is not a contraindication to proceed for surgical intervention. And this is the triaging recommendation. Emergency surgery is recommended for all patients with acute type A dissection. If the patient with type A intramural hematoma and one or more high-risk feature, even this group of patients, they are considered for surgery. Expected management may be considered for reasonable, maybe for intramural hematoma in patients with significant comorbidities and absence of high-risk feature. Other group of patients, they might be managed medically. Those who had iatrogenic aortic dissection, those group of patients might be managed medically rather than surgical intervention. The surgical planning, important thing about management of patients with group dissection is to plan your surgery before you go on. You review the CT, you plan your extent of repair, what you're going to do, from where to where, the extent of the disease and pathology, what is your strategy for cannulation, protection, everything should be planned before you go on and start your procedure. Usually the management and all of these start with preparation and the anesthesia monitoring. Monitor line includes CV line, with or without pulmonary artery catheter. Usually, patient will have more than one arterial line monitoring in the upper or lower limb to assess the pressure variation, and especially if you have peripheral and or axillary cannulation. The monitoring of the body temperature with either bladder temperature with Foley's catheter and the esophageal temperature through nasopharyngeal probe. Cerebral monitoring with the transcranial Doppler or NIRS is commonly used, especially in NIRS most of the cases.
What temperature probe do you use? Bladder or do you
Usually
use
with nasopharyngeal.
nasopharyngeal?
Nasopharyngeal.
The right answer is you have to use both.
Okay.
Because nasopharyngeal reflects brain temperature, bladder reflects core temperature.
Okay.
And there is usually a difference of 3 or 4 degrees between the two. When you cool down and you want to start your circle rest, you look at the nasopharyngeal temperature or brain temperature.
Mm-hmm.
Once you reach the desired nasopharyngeal temperature, you initiate your circle rest. But the bladder temperature reflects the core body temperature. And this is what you look at when you come off bypass. So let's say usually there is a lag between the two. Usually core temperature is higher than nasopharyngeal temperature. And it lags about 3 or 4 degrees behind the nasopharyngeal temperature. Core body is for coming off bypass. Nasopharyngeal is for initiating the circle rest.
Okay.
Another important thing in the monitoring, anesthesia monitoring, is the arterial lines. How many arterial lines are you going to put?
Bilateral upper limb and one femoral line.
Sure. It's better to monitor arterial line blood pressure in multiple arterial territories, but usually bilateral upper extremity is sufficient.
Mm-hmm.
Why do you want to monitor both radial arteries?
Because if the dissection is propagating to one side to the other, I can assess. Even if I'm using the axillary cannulation, I can assess the perfusion pressure through that side, the right side.
Okay, I mean the main reason is when you go and bypass via the right axillary artery, and you put an arc line in the axillary artery. Okay, what's going to happen if you're on bypass on the axillary artery? What's going to happen is a falsely elevated pressure
the right side.
And the right side. If you monitor only the right side, you will have a falsely elevated pressure on pump. You will keep giving nitro or things to drop your pressure while it's falsely elevated. And it does not reflect the actual perfusion pressure because the line is so close to the artery, you're cannulated. Do you guys get the point? So you have to monitor the left side, which reflects the true perfusion pressure in that case. Okay?
So, Dr. Haytham, do you use really the bladder probe?
Yes. We always use bladder or temperature probe.
Yeah,
for
because
temperature.
it's more accurate. I'm not talking about the rectum. I mean bladder.
Yes, we use it.
Okay.
We use bladder temperature to monitor coming off bypass, to monitor the temperature. Or sometimes we use the actual blood temperature in the bypass machine. Okay?
Oh, okay.
Thank you.
So, doctor, why the axillary gives a higher reading, not lower reading?
Because your arterial line is in the right radial artery, okay? And you're cannulating the axillary artery. The pressure, the cannulated artery is very close to the artery you're monitoring. Is this clear? And imagine your cannula or your graft bypass is in the right axillary artery, and you're putting an arterial line in the right radial. The reading you will get from the radial is falsely elevated.
Yes, it's clear.
Is this clear? because
Yes.
the return cannula is in the axillary artery. It gives you high pressure. And perfusion pressure is one of the parameters we carefully monitor during bypass. You want perfusion pressure to be between 50 and 80, or 55 and 80 perfusion pressure. You don't want it too high or too low. So if you have an arterial line in the right, only one arterial line, and your inflow is in the axillary artery, this will be inaccurate reading, okay? That's why you need another arterial line in a different arterial territory to monitor perfusion pressure on pump. I hope this is clear.
Yeah, it was clear. Thank you.
Next step is the planning for the cannulation site and the plan of protection. So as a general principle for the cannulation and perfusion is to establish an antegrade systemic perfusion whenever possible, alleviation of malperfusion and end organ ischemia by restoration of the true lumen flow, as well as organ protection during the episode or a period of aortic cross clamp and circle rest that can be achieved by systemic temperature management, either separate or in conjunction with retro or antegrade perfusion, plus cardioplegia and, as I said, brain perfusion strategy. Most of the cannulation steps of the aortic dissection are straightforward. The most important thing that need more thoughtful assessment and evaluation is the arterial cannulation. And this depends on your the dissection anatomy, your planning for intervention if you are planning to do arch or hemi-arch replacement. All these will have considerable effect in your decision to which cannulation site, as well as the involvement of the dissection. If the, for example, the femoral artery are dissected, if the axillary artery are even involved in the dissection, these will change the plan for cannulation. So for arterial cannulation, commonly used access right axillary artery, the femoral artery, or the evolving direct ascending aortic cannulation. Most commonly used in Europe, with almost 50% of cases, is the right axillary artery. And this represents 36% of cases in North America. The benefit of this is providing a direct access to the right carotid artery, and this is useful in cases of selective antegrade perfusion if you are going to do an arch or hemi-arch repair. And in fact, no randomized study to compare the outcome of these different strategy, but there are some reports from registry and retrospective studies, like the one from STS database with almost 7,300 patients. The axillary cannulation was associated with lowest risk of stroke development. Other meta-analysis of 8 studies, including around 800 patients. Axillary cannulation associated with reduced risk of in-hospital mortality and permanent neurological deficit compared with femoral artery cannulation. The direct aortic cannulation, it's actually providing a more physiological antegrade perfusion by cannulating the ascending aorta, and usually it's performed through a self-digital technique with the aid of transesophageal echo. And many studies have shown a similar outcome with regard to stroke and mortality when comparing both axillary and the central cannulation, not the femoral cannulation. For the venous cannulation, it is usually straightforward, obtained usually through the right atrial with a 2-stage cannula. In certain cases, if you're planning to give retrograde cerebral perfusion, then bicaval cannulation should be obtained. Left ventricular vent is necessary, especially in the setting of aortic regurg. Cardioplegia is usually administered through retrograde and direct coronary ostial catheter. This is the this graph showing the surgical anatomy for right axillary cannulation through an incision 1 centimeter below the right clavicle. You incise the pectoralis muscle and then you expose the artery. You do your cannulation through a Dacron graft 8 to 10 millimeter tube graft, not directly to the artery. It can be done actually directly to the artery, but the complication rate is higher. So almost everybody is doing through tube graft. This is showing the other technique, a Seldinger technique with the aid of the TEE. You insert the needle and the wire through the true lumen, and then you introduce the catheter over the wire to achieve the flow through the true lumen. For the cerebral protection, usually most commonly used mechanism for cerebral protection is deep hypothermia, but with or without the neuroprotective adjunct. And the endpoint for cooling for the protection is to assist for either temperature, the gold temperature, or the EEG silence. The straight hypothermia, usually during circadian arrest, usually you are cooling for 45 minutes. And the target is around 18 to 21. This is without adjunct like cerebral perfusion. But if you are utilizing cerebral perfusion, many studies showing safe, moderate hypothermia for a good duration of time. That's enough for you to do your anastomosis smoothly with less cerebral complication. Pharmacological adjunct like methylprednisolone, lidocaine, magnesium, Lasix, and mannitol might be utilized as well to add more protection, but no much evidence to support its actual benefit. So to date, with regard to cerebral perfusion, as we said, we have the antegrade cerebral perfusion, either through the right axillary artery with a clamping of the right innominate artery, or if you are doing an arch with a selective cerebral perfusion, or a retrograde perfusion through this SVC. There is one randomized trial compared the perfusion through antegrade and retrograde, and there was no difference in terms of stroke, MRI imaging, or neurocognitive studies after total arch replacement. And another large series of data done by O'Hara and colleagues, they examined the STS database of around 6,400 patients, and the utilization of both techniques was compared. There was reduced risk of death and stroke when comparing the hypothermic circulatory arrest in comparison without cerebral perfusion. So utilizing a cerebral perfusion had a more benefit in reducing the death and stroke in comparing without with only straight hypothermia without cerebral perfusion.
Okay, can I comment on this? There is a lot of selection bias in this, because surgeons who use cerebral perfusions are those surgeons who do more dissections than the others, and surgeons who don't do cerebral perfusion are low volume surgeons who don't do a lot of dissections. Therefore, their outcomes could be worse just because of the fact that they don't do a lot of dissections. Regarding antegrade and retrograde cerebral perfusions, there are animal studies on both. Animal studies on antegrade cerebral perfusion versus retrograde cerebral perfusion showed that retrograde cerebral perfusion does not provide any nutrients to the brain. Actually, most of the retrograde blood going back to the SVC, it goes to the venous system of the face, to the thyroid, to the facial circulation. What reaches to the brain is only 10%. But it's effective in actually cooling the brain. It provides like a cooling jacket to the brain. So it just gives you a uniform cooling. But the amount of nutrients going to the cell is very, very minimal. And your goal of cerebral perfusion is to provide oxygenation, basically. Oxygenation to the neurons in the brain. This is achieved by antegrade cerebral perfusion. Another thing that's very important in antegrade cerebral perfusion, you have to know how to give it, how to administer it, what's the rate, what's the flow, what's the pressure. Are you going to talk about this or no?
Actually, I did not mention, but usually the target pressure is around 70 to 80 millimeter mercury, and
Okay.
you adjust the flow to achieve this target of pressure.
Okay, so basically all this work in antegrade cerebral perfusion was done mostly by one principal investigator in California, Randy Greep, or Randall Greep. He's actually the surgeon who first developed the technique of hypothermic circulatory arrest in the 1970s. And then antegrade cerebral perfusion was developed. I think axillary artery was developed in Japan, and then selective antegrade perfusion by cannulating the head vessels was also simultaneously developed. So Randy Greep did a lot of work on antegrade cerebral perfusion and what's the optimum pressure, what's the optimum flow. Okay, and the optimum pressure is 50 to 70 millimeters of mercury, not more than 70. The higher pressure you give the brain, there is more embolic load on the brain. So antegrade cerebral perfusion is not without its complications. If you give at high pressure, it can be detrimental on the brain. Flow is between 10 to 20 cc per kg per minute. This translates to approximately 1 liter per minute to most patients. Okay, so higher flow is not good. And the same is low flow is not good. So you have to reach that sweet spot in the middle where you can actually perfuse the brain without causing damage. Okay, Mohammed.
Okay. So this is the recommendation from the SASS consensus. The right axillary cannulation and the direct aortic cannulation are both level 2A, or class 2A, while femoral artery cannulation is 2B, as per their recommendation. The addition of cerebral perfusion during the circulatory arrest is a reasonable option, and moderate hypothermia is reasonable if you are utilizing this perfusion. So after establishing your cannulation and you are applying your cross clamp, usually you will start your incision in the outer layer of the aorta. Usually a hemorrhagic plane will be found and the intimal tear will be obvious. You will transect the ascending aorta just a few millimeters above the level of the aortic commissure, and then you will evaluate the proximal part of the aorta with the aortic root, the valve, the coronary ostia, and to assess the extent of the aortic dissection. Here, the management of the aortic root and as well as the aortic valve will depend on the extent of damage that has occurred to those structures. And as a principle for the management of the root is to restore a well-functioning aortic valve, obliterating any false lumen, and alleviate the coronary malperfusion. And it's very important when considering your repair strategy for the root to put in your mind your surgical experience, because some replacement or repair strategy may need a more experienced surgeon to obtain a good result. Most patients with aortic dissection who had aortic regurg, the regurg is caused by the flap that extends below the sinotubular junction and causing a detachment and prolapse of the aortic valve leaflet. And this you may also extend usually to the non-coronary or coronary sinus. And in most patients, up to 85% of them, valve sparing with the repair and resuspension of the valve leaflet and obliteration of the false lumen will give a successful result. And this diagram showing the dissection tear and the extension of the flap up to the sinotubular junction and below the valve leaflet, causing prolapse of the leaflet. This the B image showing the affection, the dynamic affection of the dissection flap and causing malperfusion through the right coronary. So, as we said, most patients, the management of the root will be the leaflet resuspension and creation of new media and obliteration of the false lumen would be enough by utilizing double bridged stitch to resuspend the 3 commissures, and then using Teflon felt either one in between through making a new media, or sometimes using one outer and one inner layer and suture over it to obliterate the whole false lumen would be sufficient to repair the root, especially if there is no affection of the valve leaflet itself or the coronary ostia. This is another image for almost the same principle, extending the same principle, resuspension of the leaflet and then creation. Here, utilizing an inner and outer layer of Teflon felt to create the new media. So there are different scenarios that one may face in examining the aortic root. Either the aortic sinuses would be normal or minimally dissected and are not enlarged, but the aortic valve cusps are diseased. Then in this situation, aortic valve should be replaced along with a supracoronary ascending graft, leaving the root without intervention, or maybe just obliteration of the false lumen if it's present. In case of the root replacement, in case of root aneurysm or intimal tear within the root, then a root replacement most of the time is recommended, and especially in patients with Marfan syndrome or other connective tissue disease, then it is reasonable to replace the root and minimize the risk of future reintervention. If the cusps are good, of good quality, then a valve-sparing root replacement with either reimplantation or remodeling technique may be considered, but this is usually with experience, with a large experience, because there are a lot of technical pitfalls that might occur during this procedure. Otherwise, root replacement with a composite graft, either biological or mechanical valve graft, should be considered. Like if there is an affection of the valve and the root is affected, then a composite graft, biological or mechanical, or what's called a Bentall procedure. This is the showing a composite graft replacement in which you are dissecting the sinuses till the aortic root and mobilizing the coronary ostia with a button, and then taking your stitch matrix suture all over the aortic annulus, and then implanting the conduit bioprosthetic or the prosthetic graft to the root, then reattach the coronary ostia to the wall of the tube graft, making sure it's not stretched, not kinked, well oriented. And after that, you will do the distal anastomosis. And I forgot to mention that after initiating putting the cross clamp, usually you will start cooling your patient down, and you will do all this assessment of the proximal part of the aorta during this time till you achieve your target temperature. Once you have achieved your target, this is the remodeling or reimplantation technique, in which you preserve the valve, but you replace the root with a tube graft. You're making a tongue, you excise the sinuses, and then you tailor the tube graft to suture it around the commissures, and already you mobilize the coronary ostia. Eventually you reimplant to the Dacron graft. This is what's called like a Jacob procedure. Some may use the remodeling technique using a sinus graft, in which you will excise the sinuses, and then with a pledged stitch you will suspend the commissure, the 3 commissure, and then you will reattach these commissure through the sinus, the tube graft with the sinuses, which mimicking the sinuses that you have excised. And in the same fashion, you would reimplant the coronary ostia. As you said, during the time of cooling, you will manage the proximal part of the aorta, the valve, the root. And once you achieve your target temperature, then you will go to assess and manage your ascending aorta and distal anastomosis. And it is usually the most likely segment to have the rupture, the ascending aorta. And the objective of surgery is to resect all vulnerable aortic tissue, including the primary entry tear, and restore the flow in the true lumen. As a general principle in doing the distal anastomosis, open distal anastomosis show some superiority than making the distal anastomosis on a cross clamp. And this is because when you do your anastomosis on an open patient and during circle rest, you have the ability to resect the whole diseased tissue, and you can look if there is any other secondary entry point or any other tear that is involved within the aortic arch or even the proximal descending thoracic aorta, in which you may go to do hemiarch or total arch. And repairing the for the distal anastomosis, there are different techniques to do your anastomosis, either with just fine suturing, taking all tissue together and suture it to the tube graft, or by creating a new media with either a Teflon felt or pericardial tissue that help reinforce the aortic tissue and suture on a more stable anastomosis. Another technique is to use the folded adventitial collar, and then you suture your distal tube graft to it. As recommended, they usually circle rest and open distal anastomosis is preferred with class 1. The extent of aortic resection should include the entire ascending aorta and the primary entry tear. For type 2 DeBakey dissection, most of the time you have the ability to resect the whole diseased tissue because it's just limited to the ascending aorta, and this is your procedure most of the time will be considered as a curative procedure. But for type B, type 1 or DeBakey, your procedure or your repair, most of the time it's a palliative because still some false lumen either within the proximal or all over the descending thoracoabdominal aorta. If you examined your arch and you found that the arch is affected, either you go for hemiarch, or sometimes, especially if the coronary, these arch vessels are affected, you go for the total arch replacement. And the technique for arch replacement, either to use the island technique, in which you resect the aortic arch tissue with the island involving all arch vessels, and then you do your distal anastomosis, and then at the arch anterior superior aspect you anastomose the island to the graft, then you do the anastomosis to the proximal tube graft. Other technique, if the arch vessels are severely affected, then direct reimplantation or reimplantation through the branched graft can be achieved. And this is the recommendation for root for the arch management. Extended arch replacement is reasonable with class 2A in patients with acute dissection. And if the tear is in the arch or proximal descending aorta, or if there is an evidence of brain or peripheral malperfusion, or even if the arch or descending thoracic aortic aneurysm, there is ascending, there is arch aneurysm or rupture. Extended aortic arch replacement with frozen elephant trunk may be reasonable to promote a favorable aortic remodeling as it's shown that utilizing the either the Dacron tube or the stent with superiority of the stent, it will enhance the obliteration of the false lumen and the remodeling of the aorta, and also will facilitate further TEVAR for the remaining descending thoracic aorta. One of the common complications that usually faced with those group of patients is malperfusion, and management of malperfusion is very essential to put in mind while you're managing your patient. It's usually a life-threatening complication with a reported incidence of about 15 to 40%. Peripheral perfusion, malperfusion, less common. The spinal cord malperfusion reported around 2 to 5%, mesenteric 4 to 6%, and renal malperfusion around 9%. But if it occurs, it's usually lethal. End organ dysfunction, it can exist from systemic inflammation to overt organ infarct. And the usual tradition, the tradition for managing such a patient is to treat the proximal aortic disease first in order to restore the true lumen flow. And most of the time, restoring the flow through the true lumen will obviate the malperfusion, especially if it's due to a dynamic malperfusion. But in cases of static malperfusion, like if there is a true rupture of the branch, usually the malperfusion will not be resolved by repairing the proximal part. And for those kind of patients, further intervention to establish a flow and perfuse the affected organ has to be taken. Though some recommendations supporting that proximal aortic repair can be delayed until definitive treatment of distal malperfusion, specifically mesenteric malperfusion. Many will argue that a very lethal and high mortality risk of ascending aortic aneurysm should not be delayed till achieving a definitive management of distal malperfusion.
Can you go back to the slide, Mohammed?
Okay.
Mesenteric ischemia in acute dissection is a different story. It carries a very, very high mortality. Mortality in mesenteric ischemia is up to 60%. So it is not unreasonable to address it first percutaneously with the stenting of the SMA. This is now coming from large center series, like the University of Michigan, Ann Arbor, for example. And their protocol now is to address malperfusion before addressing type A dissection. Now, this comes at the risk of actually delaying your surgery, but mesenteric malperfusion patients do bad even if you operate on them. So relieving the mesenteric ischemia before surgery is not unreasonable. This evidence is not written on hard stone. This is only single center experiences and things like that. So the evidence is not solid, but it makes sense in cases of mesenteric ischemia. In cases of lower limb perfusion, we had a recent discussion in our center here. In cases of lower limb malperfusion in association with type A aortic dissection, a simultaneous procedure can be done, like a FEM-FEM crossover bypass. Simultaneously with the repair of type A dissection can be done. But as Mohammed said, if the obstruction is dynamic, usually it's relieved by the repair of proximal aorta. You actually relieve the obstruction and the malperfusion if it's dynamic. Carry on, please.
Dr. Haitham, most of the time, it will be difficult to know if it's a dynamic or a static malperfusion for the distal organ, even for the mesenteric. So
it is difficult to know. Usually dynamic obstruction comes and goes. Like they have pain in the leg that comes and goes. This is dynamic, most likely. But it is very it's difficult to differentiate between both. You're right.
I mean,
Yeah.
aren't we risking delaying the repair of the proximal repair for something that might be dynamic and might be resolved with our procedure?
You are, but in mesenteric ischemia, honestly, if you have full-blown mesenteric ischemia, it's really hard to call it dynamic, because dynamic obstruction improves it with the flap movement. You know, the dissection flap is dynamic; it moves. So once you drop the blood pressure with anti-impulse therapy, actually it does improve. You actually minimize flow in the false lumen. But if you have a full-blown mesenteric ischemia, I think it's really hard to call it dynamic. And I think many centers now prefer to send them for percutaneous stenting. It's really hard to convince your interventional radiologist to do this here. What we do here is just to take him to the operating room. But mesenteric ischemia any is a very bad disease if it's associated with dissection. So yeah.
Can we?
Yeah, we just take them to the operating room. We don't delay. But what I'm saying is, it's not a bad idea actually to consider fixing the malperfusion first. What's the right thing to do? Nobody knows.
Okay.
Okay.
Can we take such a patient to a hybrid OR and?
You can, yeah, for sure.
Both,
a lot of surgeons now have percutaneous capabilities, and we can do hybrid things. Yeah.
Okay.
For sure. Yeah. Okay.
So
continue.
The surgical outcome of such a group of patients, initially in DeBakey initial DeBakey report, it was reported that operative mortality is around 40%, but recent report is around 10 to 30% operative mortality. And usually the mode of death is either stroke, myocardial ischemia, heart failure, aortic rupture, or malperfusion, as we discussed earlier. The IRAD recently reported on the result of 500 plus patients with type A aortic dissection who underwent surgical treatment in 18 large tertiary centers. And the overall mortality was reported around 25%. 31% for hemodynamically unstable patient, and for stable patient it was only 17%. And the majority of patients, the cause of death was due to aortic rupture, followed by neurological complication. The visceral ischemia constitute around 12% of patients, and around 42% for non-specific reason. And the long-term survival for these group of patients following surgery is roughly around 71 to 89% at 5 years, and around 66% at 10 years. I think this concludes my talk. I did not speak further about the what after doing you do your distal anastomosis, the de-airing process, and the further usually it comes in a routine steps as
okay. It's a big topic, Muhammad. It's a very big topic. Type A aortic dissection, so many controversies now, so many techniques of doing it. But my question is, what impacts your long-term survival after type A repair? What's the most important determinant of long-term survival?
Obliterating the primary entry tear, and usually even the result shows a long-term survival and less risk of reoperation for those patients who the distal anastomosis is done in an open technique, because you are sure you are doing a very healthy tissue, and there is less risk to have another entry tear or redissection that can.
That's correct. That's correct. So what impacts your long-term survival after type A aortic dissection repair is patency of the false lumen. If you have a patent false lumen post-repair, if you have a perfused false lumen with dense contrast in it, this will tell you that the dissected aorta basically this arch and descending will continue to grow long term. And when they continue to grow long term, is at risk of complications. Now, the trend in major aortic centers, if you have a DeBakey 1 dissection, which is basically like an extensive type A all the way down, is to do a total arch.
Mm-hmm.
A total arch with either frozen or conventional elephant trunk. Basically, to address the issue of long-term or late reoperation. The rate of late reoperation with all comers in type A dissection is about 30%. This can be reduced if you to 10 or 5 or 10% if you do a total arch in the first operation. But again, if you do a total arch, you make it a bigger operation, especially late at night, you may impact your short-term survival. The gold standard operation is a hemi-arch, standard hemi-arch with an open distal anastomosis. That's the gold standard operation, the bare minimum you can do for aortic dissection. Okay? Repair of the root, either by a Bentall or valve sparing root replacement, as you said, Muhammad, only limited situations where you have number one, either an aneurysmal aorta, an aneurysmal root, if the root is big, or if the initial entry tear is in the root. These are the only situations where you do a root replacement. Dissected roots, dissected coronaries is not an indication.
Mm-hmm.
It's actually an indication to avoid doing a total root. Let's say you have a dissected RCA. Simply by fixing the layers with bioglue or with felt, you can avoid doing a full root replacement in these patients. You just do a supracoronary graft and a hemi-arch replacement. Only do a Bentall if you have to in these two situations. One, large root. Two, primary tear in the root. Okay?
Okay.
Any questions?
Any questions?
Seriously, no questions? Everybody understand dissection now? Good.
Okay, thank you, Dr. Haitham.
Thank you, Dr. Haitham.
So,
Sorry?
thank you so much, Dr. Haitham.
You're welcome.
I am Ahmed Silboui, moderating the activity for today. So, thank you so much for your attendance, and
My
really
pleasure.
we appreciate your time.
With pleasure. Okay,
So,
you're welcome. Thank you.
Thank you, Dr. Muhammad, for your great presentation. So we will have a break for 10 minutes, and then we'll be back with Dr. Al-Matlaq with endovascular therapy for type A aortic dissection therapy. Dr. Mohammed, are you ready?
السلام عليكم. يا ريتي. السلام عليكم، يعطيكم العافية. واضح الصوت؟
إيه واضح.
طيب. My name is Dr. Mohammed Al-Mutlaq. I have 3 cardiac surgery in Cloud Hospital. So today I will talk about endovascular treatment of type A aortic dissection. Endovascular stent graft is the stent graft synthetic fabric tube supported by metal wire stent is used to repair the aorta from within. Endovascular surgery involves making the repair inside the aorta. A small incision is made in the groin and catheterized, and the catheter with the fabric lined stent attached is delivered and deployed into the aorta under X-ray guidance. At the repair site, the stent graft is released and like a spring or umbrella open up the line and provide a reinforcement to the weakening area in the aorta. Endovascular repair of the aorta has become an established treatment for acute aortic dissection, aneurysm, and intramural hematoma of the descending thoracic and abdominal aorta. In contrast, the ascending aorta has previously not been considered amenable to endovascular repair due to anatomic and physiological limitation. The ascending aorta is more dynamic than descending thoracic aorta and undergoes faster conformational change with each heartbeat. In contrast, stent graft used for endovascular repair are relatively static and are at the risk of being dislodged due to very dynamic environment of ascending aorta. Additionally, the curvature of ascending aorta, location of the origin of the brachiocephalic artery, sinus segment effacement, coronary artery origin are all important considerations when the planning an endovascular strategy for ascending aorta. Acute type A aortic dissection is the typical fatal when not treated urgently. The gold standard for treatment continues to be open surgery for these patients. However, if the patient is poor candidate or otherwise at prohibitive risk for surgery, medical management is employed to maintain the blood pressure control and to reduce the risk of rupture. Endovascular repair should only be considered when the patient is poor candidate for surgery due to comorbidities, and when the anatomy of the ascending aorta and the dissection is amenable to endovascular repair. Due to considerable challenge present in ascending aorta, the pool of the patient for whom endovascular repair is considered appropriate is small. The lesion must be anatomically amenable to endovascular repair. There must be proximal and distal landing zone of at least 20 millimeters in average that do not compromise the coronary ostia or brachiocephalic vessels. And the ascending aorta must accommodate the stent graft within the treatment sizing range. Additional, coronary revascularization procedure can be demonstrate an important limitation for endovascular repair in ascending aorta because the previous coronary bypass graft may be occluded with the stent graft coverage in ascending aorta, and the presence of stent may be prevent future revascularization. Moreover, in the patient with acute type A aortic dissection, successful endovascular repair may be insufficient because of the frequent comorbidities of the dissection itself. In fact, an average of 1/3 of all patients with acute type A aortic dissection may present with the progressive tamponade or moderate to severe aortic regurg. Lastly, in order to select the correct stent graft size and guarantee sufficient long-term durability, one needs to understand the dissection-induced geometric change of ascending aorta. In fact, in order to offer an endovascular repair therapeutic option for the patient unfit for open surgery, there are 3 main considerations that require further illumination: geometrical, anatomical, and clinical. Geometrical consideration: an endovascular repair in the setting of acute aortic dissection is defined as the closure of the primary entry steer, induction of the false lumen thrombosis, and true lumen expansion. Stent graft diameter has to be sufficient expanding the true lumen, but most not result in the formation of new entry or even cause rupture. The three important things we are learning on geometry change of acutely dissected ascending aorta. First, there is an induced average of increase in the mid-ascending aorta diameter of 32%. Note the diameter increase indifferent at the level of sinotubercular junction and distal ascending aorta at the level of offspring of the brachiocephalic trunk. The length of the aorta does not change when it dissected, even though it may be a predictor of ascending aorta dissection. 3, the increase in the diameter of ascending aorta is independent of patient age, height, and weight. Therefore, we are able to adequately calculate the pre-dissection aorta diameter from post-dissection by CT scan in order to effectively determine the adequate stent graft size and corresponding to the original media diameter of the aorta. To the date, it is unclear whether we can achieve technical success with the short, straight stent graft or whether the different diameter increase in the proximal and distal aorta may require taper stent graft. Consideration compared to descending aorta or abdominal aorta bifurcation, the ascending aorta is significantly shorter, and therefore ascending aortic stent graft have to be significantly shorter too. To cover the area of ascending aorta is limited proximally by coronary arteries or by aortic sinus, and distally by offspring of the brachiocephalic trunk. Moreover, the length of the stent graft is limited by available proximal and distal landing zone. The most common criteria and endovascular treatment was the lack of the sufficient proximal landing zone and distance between the more distal coronary artery and the entry tear has been measured to be less than 20 millimeter in average. Thus, in order to treat more patients, it seems inevitable to reduce the length of the stent graft landing zone. However, without additional anchorage, this may be increase the risk of the stent migration and endoleak development. Clinical consideration: up to 1/3 of all patients with acute type A aortic dissection present with the cardiac tamponade of the moderate to severe aortic regurg, and both conditions require prompt treatment. However, cardiac tamponade may not be limiting factor for endovascular treatment when considering a transapical approach for stent graft deployment. In fact, transapical approach would not only resolve the issue of cardiac tamponade, but would also simplify the true lumen wire placement while avoiding the steep aortic curvature at the aortic arch. The transapical approach is routinely used option by cardiac surgeon. Nevertheless, significant aortic regurg will most likely to be treated by simple stent graft deployment. Systemic review of the report endovascular repair of ascending aorta published between 1995 to 2017 found 46 publications detailing primary endovascular repair of the ascending aorta using stent graft in total 118 patients. Most of publication were case report or series with 10 or fewer patients, although one series reported outcome for 15 patients and the largest series containing 21 patients. Half of 118 patients, around 50, have the type aortic dissection. Patients are also treated with our aortic pseudoaneurysm of around 30%, aortic aneurysm 5%, penetrating ulcer and the result of atherosclerosis 4%, aortic rupture 2%. The most common approach were transfemoral or transapical. The delivery system for stent using for repair dictated the approach of some patients. Endoleak of complication. A complication is unique to endovascular stent that occur when the blood leak around the outside of the stent, occur around in 18% of the patient. This is significantly higher than incidence of endoleak report for thoracic descending aorta, less than 10%, and leak limitation of current technology. Other complications include postoperative myocardial infarction, 3%, cerebrovascular complication, 3%, stent migration, 2%. Respiratory complications have also been reported after endovascular repair in ascending aorta. Of the 118 of endovascular procedure, around 3.4 required conversion to the open surgery, and 11 required surgical intervention. This is 9%. In other series of endovascular repair of ascending aorta published, 9% of the procedure requires conversion to the open surgery, and 32 of the survivors, 6 out of 10 of 19, require surgical intervention. 6, it is worth noting, however, that the 2 of these 3 interventions were planning prior to the initial endovascular repair. In systemic review, all cases mortality after endovascular repair of ascending aorta was 15%, and our aortic-related mortality was 5%. 2/3 of the patient, around 67%, remained free of aortic-related complication during follow-up, and 60 did not experience any complication during the follow-up. This is a clinical presentation. 91 years old male patient was taken to the hospital following sudden collapse. He complained of the back and abdominal pain as well as overall weakness. CT scan showed an acute type A aortic dissection, and the patient was emergently transferred to the department on the moderate catecholamine dose. Transesophageal echo in admission demonstrates pericardial tamponade. His medical history include diabetes mellitus, COPD, hypertension, stage 3 chronic renal disease, prior endovascular abdominal aortic reconstruction, prior nephrectomy, an implanted pacemaker, a stent in the right coronary artery. Given his prohibitive surgical risk, advanced age, and favorable location of aortic dissection, surgeon choose an endovascular repair. And we see here, this is the video. The entry tier was located in the ascending aorta, just at the beginning of the laser curvature of the aortic arch, with the distal landing zone around 25 millimeter and proximal landing zone 60 millimeter. The largest diameter of the ascending aorta was 41 millimeter. The descending aorta neck vessels were noted involved under general anesthesia. Cardiopulmonary bypass was established via the femoral artery and femoral vein. Cardiopulmonary bypass was necessary because the pericardial tamponade in the history was. And as the backup measurement of the case of the rupture in the ascending aorta via mini thoracotomy. At the 5th intercostal space, pericardial effusion was drained. The left ventricular apex was accessed under the fluoroscopy guidance. Ventricular fibrillation at 180. A covered straight stent, 45 millimeter diameter and 75 millimeter length, was deployed in the ascending aorta to occlude the entry of the tear. Parametal stent 42 in 70 was then deployed inside the covered stent. At the end of the procedure, the tear was well covered. A false lumen obliterating, and both are brachiocephalic trunk and coronary artery unobstructed. Postoperative follow-up for this patient, no stroke, no arrhythmia was observed during the postoperative period. The postoperative CT scan showed a good coverage of the tear, and the patient was discharged on 7th postoperative day. At the 1-year postoperative clinic visit, the patient was in good overall clinical condition, and the CT scan showed stable location of the stent without sign of the leak or stent migration. Carefully patient selection with a favorable anatomic characteristic is critical and ensure successful outcome in the patient with the endovascular treatment for type A aortic dissection. Thank you.
Thank you, Dr. Mohammed, for the presentation. So, any question or comment?
So, Dr. Mohammed, how can we identify a good landing zone for the stent? I mean, what is the criteria?
So, Dr. Mohammed.
This is the criteria. Where is it? This is 20, not less than, to be less than 20 millimeter in average. So it should be far away from the bifurcation of aorta and not less than 20 millimeter in average. Because it will be, if it will be the less, it will be we have the complication, the stent will be migrate. So it's better there is 20 millimeter, the landing zone.
So sometimes and my question, sometimes we don't cover the whole dissected area. It should be just a part of it, so we can have
Embolization.
What I mean that we shouldn't cover the whole area. We have just a part of the dissected area, so we can give good results, or it should be the whole area. So
No,
this 20 millimeter.
Yeah, I know, but this is the landing zone when the stent graft is deployed inside the aorta. So the whole dissected area should be covered.
Yeah. So what is this 20
and
millimeter?
if we have there is a branch for aorta, like left brachiocephalic or left common carotid, should be take care for this area. If the stent by itself not covering, we cannot choose the endovascular repair.
Mm-hmm. Yeah. Okay. Yeah.
So it is the solution, but for like older patient, or fit, like I said here, but this is geometrical and anatomic and clinic. Not only all patients have aortic type dissection, we can do endovascular repair.
Yeah.
If like the patient have like graft or did CABG before, we cannot use this area to put our stent because we will close the vein or the artery graft.
Okay, thank you.
Okay,
so there is a limitation, but for kind of the patient, not for the all.
Yeah.
That's the thing.
Okay. Thank you, Dr. Mohammed. So, any other questions? So, again, thank you, Dr. Mohammed Babgi and Dr. Mohammed Al-Matlaq for presentations today. And by this, we conclude our session for today, and then see you next week, inshallah.